usually when we talk about a medical diagnosis, there is this expectation of, like, total precision.
Right. It feels like engineering.
Yeah, exactly. You break your arm, they take an x-ray, it shows a jagged white line, and the doctor just points to it and says, there's your problem.
It's clean. It's either broken or not broken.
Right. But then you step into the world of women's health, specifically around menopause and aging, and suddenly that x-ray machine is just totally useless.
It really is. The diagnostic landscape gets incredibly murky.
So murky. And heavily influenced by this multi-billion-dollar cosmetic industry. So welcome to this custom-tailored deep dive crafted specifically for you. We are looking at a fascinating stack of clinical guidelines today.
We've got consensus statements from the British Menopause Society, Cochrane Library reviews, detailed FAQs from top gynecologists.
The real heavy hitters. Because our mission today is to address a highly specific, intimately important, and frankly, very misunderstood question. Does vaginal tightening actually help with vaginal dryness?
And to answer that for you, we have to aggressively separate cosmetic marketing from, well, biological reality.
Okay, let's unpack this, because if you spend even 5 minutes looking this up online, you are just bombarded with ads.
Oh, the marketing is everywhere. Lasers, radiofrequency wands.
Exactly. Expensive rejuvenation packages, and they promise to fix literally everything from leaks to laxity to dryness. It's overwhelming.
It is. But before we can even evaluate if a laser or a wand can fix dryness, we have to look at the medical reality, which is GSM, or Genitourinary Syndrome of Menopause.
Right. We need to understand the root cause. Like, why does the tissue become dry and painful and feel lax in the first place?
Well, it fundamentally comes down to dropping estrogen levels, usually during perimenopause and menopause.
Because estrogen is kind of the boss down there, right?
It acts as the master regulator of the entire urogenital tract, yeah. You have estrogen receptors located all throughout the vagina, the urethra, the bladder trigone, and even the pelvic floor.
That's a lot of real estate depending on one hormone.
It is. And when those receptors are actively receiving estrogen, they maintain this highly dynamic microecosystem. And honestly, one of the most remarkable details from the clinical data is the sheer speed at which this system operates.
Oh, yeah. I definitely want to highlight this for the listener.
In a well-estrogenized vagina, the superficial mucosal cells turn over every 4 hours.
Wait, I really want to pause on that because it absolutely blew my mind when I read it in the notes. Every 4 hours.
Every 4 hours. It's a relentless pace of cellular regeneration.
That is just wild. I don't think people realize their body's working that fast down there. I mean, 4 hours is nothing.
It's a phenomenal rate of turnover, and it serves a very specific biological purpose. When those superficial cells turn over and break down, they release a substance called glycogen.
Which is a type of sugar.
Exactly, a complex sugar. And that glycogen acts as the primary food source for the local beneficial bacteria, specifically the lactobacilli.
Okay, so the cells die, release sugar, and feed the good bacteria.
Right. And then the lactobacilli consume that glycogen and produce lactic acid as a byproduct.
Ah, lactic acid. So that's what controls the pH.
You've got it. That lactic acid keeps the vaginal environment acidic, usually maintaining a pH under 4.5.
So what does this all mean for you listening? It's kind of like a lush, self-hydrating rainforest ecosystem. You have the rain, which is the estrogen, and that feeds the plants, which are the cells.
That's a great way to visualize it.
Right. And then the plants drop, leaves the glycogen, which feeds the soil microbes. It's this continuous, self-sustaining loop. So what happens when perimenopause hits and that estrogen range just suddenly stops?
Well, the 4-hour cycle basically halts. The superficial cells start turning over at that rapid pace.
So the food supply gets cut off.
Exactly. The glycogen supply dries up, which means the lactobacilli starve. Without them, lactic acid production plummets and the pH rises.
And a higher pH means trouble, right?
Definitely. The environment becomes much more hospitable to bad bacteria. That's why recurrent urinary tract infections become so incredibly common during this time.
And physically, what's happening to the tissue itself?
It thins out significantly. It becomes pale and friable, which means it tears easily. The natural folds of the vagina, called rugae, they just flatten out.
Man, that sounds so uncomfortable.
It is. Furthermore, the fibroblasts in the vaginal wall, those are the cells responsible for producing collagen and elastin. They go totally dormant.
Which brings us back to the symptoms of GSM. Clinicians describe women experiencing like paper-cut micro tears or this awful sandpaper friction feeling during really basic activities.
Just walking or exercising can become painful.
Right, and dyspareunia too, which is severe pain during sex. It sounds incredibly disruptive. It really reframes the whole issue. This isn't just a sudden, mysterious dry spell that you can just ignore.
No, not at all. The British Menopause Society stresses that GSM is a chronic, progressive biological condition.
So it's not going to just magically get better on its own.
No. Unlike hot flushes, which might eventually fade over time as the body adjusts, GSM symptoms typically worsen if left untreated because the anatomical structures are fundamentally degrading.
Right, the rainforest is drying out, the structural integrity is weakening, and obviously the cosmetic and medical device industry saw a massive market opportunity here.
Oh, huge. If the problem is thinning tissue and dormant fibroblasts, well, the skincare industry has been dealing with that on the face for decades using energy-based devices.
They just took that facial technology and brought it south.
Pretty much, yeah.
Because looking at these brochures, they push these really specific treatments. Fractional CO2 lasers, erbium YAG lasers, and radiofrequency devices. I mean, I don't even know what those mean in this context. How do you use a laser inside the body to fix dryness?
Well, these devices use targeted thermal energy, basically controlled heat. A clinician inserts a wand that delivers this heat to the vaginal epithelium and the submucosal tissue just beneath it.
Just literally heating it up from the inside.
Yes. And the difference between the devices mostly comes down to how they deliver that heat. A CO2 laser is highly absorptive in water, so it aggressively heats the tissue and creates microscopic columns of ablation, tiny, controlled injuries.
Ouch. That sounds intense. What about the others?
An erbium YA laser does something similar, but often with less thermal spread, so it's a slightly different recovery profile. And radiofrequency doesn't use light at all. It uses electromagnetic waves to heat the deeper tissues without necessarily ablating or burning the surface.
Okay, but how does burning or heating the tissue actually help anything? It sounds like we're just damaging an already fragile, dry area.
Think of it like the microneedling treatments used in facial dermatology. By creating a tiny controlled injury, you trick the body's natural healing response into rushing to the site.
Ah, okay. The body hits the panic button and sends help.
Exactly. The heat forces those dormant fibroblasts we mentioned earlier to finally wake up. They start producing new collagen in a process called collagen remodeling, and they stimulate angiogenesis.
Angiogenesis, meaning new blood vessels.
Yes, the formation of new blood vessels, bringing fresh blood flow back to the area.
I can totally see why this is pitched as a lifesaver for a very specific group of women.
Yeah.
I mean, the sources point out that for women who absolutely cannot use hormone replacement therapy, maybe they've had an estrogen receptor-positive breast cancer or certain uterine cancers.
Right, they might be thrust into sudden surgical or chemical menopause.
Exactly. And estrogen is completely off the table for them. So a non-hormonal energy device sounds like a critical alternative.
It is. For patients with strict contraindications to estrogen, these devices offer a real pathway to improve tissue quality without those systemic hormone risks. Clinics report really meaningful improvements in surface comfort for cancer survivors suffering from severe GSM.
But here's where it gets really interesting. Because the marketing materials I am looking at literally say vaginal tightening in huge, bold letters.
Ah, yes, the tightening claim.
Right. If a woman has structural looseness after childbirth combined with menopause, or if she has a pelvic organ prolapse where she's actually experiencing a visible bulge, won't this heat treatment shrink the tissue and pull things back into place?
The medical data is incredibly clear on this distinction. No.
No, flat out no.
Flat out no. According to systematic reviews, including the Cochrane Library, these devices do not fix geometry. They do not repair a pelvic organ prolapse.
So it's not fixing the architecture.
No, they cannot rebuild a torn perineal body or fundamentally tighten the vaginal canal in a structural sense.
Wow. So a laser isn't going to fix tampon slippage or a prolapse?
Yeah.
The tightening claim is really just a clever marketing term.
That's all it is. It's derived from the fact that collagen remodeling might make the tissue feel slightly firmer or thicker at the very surface. But if there is a structural failure, the patient needs a structural solution.
Like pelvic floor physical therapy or surgery.
Exactly. Targeted physiotherapy or a urogynecology consult. The medical consensus is that these energy devices improve surface comfort and glide. They reduce that sandpaper friction and ease the micro tears.
And I'm also noticing a ton of caveats in the clinical notes from leading gynecologists on this. The data supporting these devices seems surprisingly shaky.
It's a significant issue in the field right now. A lot of the studies are very small, they only track patients for a few months, and they rely heavily on subjective self-reporting.
Like a patient just filling out a vaginal laxity score
Yeah,
questionnaire.
right. We don't have those massive, long-term, double-blinded, placebo-controlled trials showing definitive proof yet.
Which forces us to ask the core question of this deep dive. If these devices improve surface comfort and create some localized collagen, does that actually cure the vaginal dryness we talked about at the start?
The definitive answer from clinical guidelines is no,
Not a cure at all.
not a cure. Energy devices are not a permanent fix. They nudge mechanical resilience, giving the tissue a temporary boost in durability to handle friction.
But the underlying biology...
It's still the same. The lack of estrogen is still there. That crucial 4-hour cellular turnover we talked about, it remains completely halted.
Oh, wow. So the glycogen is still missing, the lactobacilli are still starving, and the pH is still elevated. So to put it in perspective for you, the listener, treating GSM only with a laser is like trying to fix a severe drought by putting a fresh, expensive coat of green paint on dead grass.
That is a perfect analogy.
Right. It might look good from a distance, it might even smooth over the surface temporarily, but the underlying ecosystem is still totally parched and dead. You haven't actually introduced any water.
And what's fascinating here is that the UK clinical guidelines from NICE and the British Menopause Society view these devices strictly as an adjunct therapy.
An add-on, not the main event.
Exactly. Because the foundational biology isn't supported, any improvements from a laser series, which is usually 2 or 3 sessions, will naturally soften and fade over a matter of months.
Meaning you have to keep going back.
Yes, the environment drifts back to its estrogen-deprived state, requiring expensive maintenance treatments every 6 to 12 months.
That sounds incredibly frustrating, especially for someone who just dropped thousands of dollars thinking it was a one-and-done cure.
It happens all the time.
So, if expensive laser tightening isn't the primary fix for dryness, what do the medical guidelines actually demand you do first? Let's walk through the actual gold standard clinical pathway.
Sure. Step 1 in the pathway is always non-hormonal foundations. And this involves 2 distinct types of products: vaginal moisturizers and vaginal lubricants.
Can they do entirely different things?
Completely different. Lubricants are for short-term, immediate relief, applied right before sexual activity to reduce friction. Moisturizers are designed for regular maintenance.
Like face cream.
Yes. They should be used 2 to 4 times a week to mimic natural secretions, rehydrate the tissue, and actually help lower the vaginal pH back toward a healthy level.
Now, there's a really crucial scientific detail here in the guidelines about choosing these products. It emphasizes that osmolality matters immensely.
It is incredibly important.
I have to admit, osmolality sounds like a concept from a high school chemistry test I failed. What does that actually mean, and why should we care?
It does sound intimidating. Osmolality just refers to the concentration of dissolved particles in a fluid. The natural osmolality of healthy vaginal secretions is between 260 and 290 milliosmoles per kilogram.
Okay, so 260 to 290 is the sweet spot.
Yes, so when you purchase a moisturizer or lubricant, you want a product that matches that physiological range.
But what happens if you buy a product with a much higher number? Because I assume a lot of these over-the-counter drugstore products don't even list this on the bottle.
Most do not list it, which is highly problematic. If you introduce a product that is hyperosmolar, meaning it has a much higher concentration of particles, sometimes well over 1,200, it causes a dramatic biological reaction.
Over 1,200, that's way past 290.
Right. And the cell walls of the vaginal epithelium are semi-permeable. Because of the basic principles of osmosis, water will always move from an area of low concentration to an area of high concentration to try and create balance.
Oh, wait, I see where this is going. The hyperosmolar gel is sitting outside the cell.
Yes, so the water inside the cell rushes out to dilute the gel.
It literally pulls the water out of the surrounding vaginal cells.
It aggressively dehydrates them. You buy a product to cure dryness, but because the osmolality is too high, it is actively dehydrating you further.
That is wild.
The cells shrivel and sustain damage. It can markedly reduce the number of viable epithelial cells, making the irritation, burning, and microtears significantly worse.
So you could literally be making the problem worse while trying to treat it.
Absolutely. The World Health Organization recommends osmolality should absolutely be less than 1,200, but ideally matched to that 260 to 290 range.
Wow. And the guidelines also mentioned a quick safety tip here regarding lubricants. Never use oil-based lubricants with latex condoms.
Very true. The oil destroys the latex integrity, causing it to break. Stick to water-based or silicone-based if condoms are in play.
Good to know. So if step 1, the non-hormonal moisture and pH support, isn't enough to resolve the symptoms, what is step 2?
Step 2 is the true benchmark for durability and biological restoration: local vaginal estrogen, or DHEA.
Let's clarify the estrogen part first, because people get nervous about that word. Local estrogen is very different from systemic HRT,
Hmm.
right? You aren't putting a patch on your arm or taking a pill that circulates through your whole bloodstream?
Exactly. Local estrogen is applied directly into the vagina. It comes as a cream, a tiny tablet, a pessary, or even a soft silicone ring. The dosage is incredibly low, often measured in micrograms.
So it's just acting locally.
Right, it acts directly on those local receptors we discussed earlier. Because the dose is so small and targeted, it does not significantly raise the estrogen levels in the rest of your bloodstream.
Okay, that makes sense. You also mentioned DHEA alongside estrogen. I've seen DHEA sold as a supplement in vitamin aisles, but what is it doing as a vaginal treatment?
Well, DHEA, or dehydroepiandrosterone, is a precursor hormone. When it is applied locally to the vaginal tissue, usually as a daily insert, it doesn't act as estrogen directly.
What does it do?
The local cells absorb the DHEA and actually convert it intracellularly into both active androgens, like testosterone and estrogens.
So the body is doing the manufacturing work itself, right inside the cell.
Exactly. It provides the raw materials, allowing the local tissue to produce the exact hormones it needs. This is particularly appealing for women who want to avoid introducing direct, active estrogen into their bodies while still achieving the same restoration.
That is so cool. And whether a patient uses the local estrogen or the DHEA, the mechanism fundamentally reverses the condition, right?
It does. It thickens the tissue, brings back the blood flow, and most importantly, it restores that rapid 4-hour cellular turnover.
The rainforest comes back to life.
The glycogen returns, the lactobacilli thrive, the pH drops, and those UTIs finally stop.
It rebuilds the ecosystem from the ground up. But I mean, how long does this take? If someone starts using local estrogen tonight, are they cured by tomorrow morning?
The timeline does require some patience. Patients typically notice an improvement in surface symptoms, like stinging or burning, within 2 to 4 weeks.
Okay, that's not too bad.
But it usually takes 3 to 6 months for the mucosal tissue to fully rebuild its structural thickness, elasticity, and resilience.
Speaking of the application process, there's this fascinating quirk in the British Society of Sexual Medicine guidelines regarding local estrogen creams and male partners.
Ah, yes. The absorption risk.
The guidelines advise avoiding sexual contact for at least a few hours after applying the cream or pessary. Why is that?
Well, there is clinical evidence that a male partner can actually absorb a slight increase in serum estradiol through the skin of his penis during intercourse if the product was just applied.
Wait, really? Just from contact?
Yes. The tissue absorption of these localized treatments is so efficient that the medication can easily transfer.
That is wild.
It's easily avoided by simply timing the application, like inserting it right before going to sleep. But it highlights just how biologically active and potent these topical treatments really are.
It really emphasizes that we're dealing with powerful medicine here, not just some over-the-counter lotion. And when you look at this entire clinical pathway, the sequencing of treatments makes perfect sense.
Sequence is everything here.
It saves you time, it saves you money, and it prevents immense frustration. You have to rebuild the ecosystem using the moisturizers and the local hormones before you worry about the landscaping, which is the laser.
If you just take a laser to a starved, dry ecosystem, you are fundamentally wasting your money. The stepped approach prioritizes long-term, evidence-based health over quick cosmetic fixes.
Which brings us back to our core question. Does vaginal tightening actually help with vaginal dryness?
And based on the clinical evidence, the answer is heavily nuanced. Vaginal energy devices can help reduce mechanical friction and entry pain by triggering a mild temporary collagen response.
But they do not permanently cure vaginal dryness.
No, they cannot replace the estrogen needed to fuel that 4-hour cellular turnover. They can't feed the bacteria, and they can't fix the underlying ecosystem.
Without the foundational support of properly formulated moisturizers and local estrogen, any mechanical improvements from a laser will simply fade away.
Which raises an important question, and I want to leave you with a final thought to mull over. Consider the phrase vaginal laxity itself.
It's plastered all over clinic websites.
It is, but how much of our understanding of women's health is skewed by terminology that makes a natural, inevitable biological shift sound like a structural failure or a cosmetic flaw?
Framing the menopause transition as a loss of tightness implies that something is broken.
Right, it implies it requires an expensive mechanical fix. But what if, instead, we viewed it for what it truly is? A highly complex, dynamic ecosystem that simply needs a new way to be nourished.
When a drought strikes, you don't paint the dry soil green.
Exactly. You find a new way to water the garden.
You find a new way to water the garden. That changes how you approach the entire solution. Well, thank you for taking this deep dive with us today. We hope it brought some much-needed clarity to a really murky diagnostic landscape. Until next time, keep questioning the marketing buzzwords and take care of your ecosystem.